Hello everybody, welcome to our Radiology Quiz 2 about chest X-ray. Let us begin. Question 1. Which finding is present on this image? 1. Normal X-ray image. 2. Sale sign. 3. Meniscus sign. 4. Pneumothorax. 5. Air bronchogram. The correct answer is meniscus sign. This is the classic meniscus sign of a pleural effusion. Question 2. Which finding is present on this detail image of the left lung? 1. Mesothelioma. 2. Asbestosis. 3. Pleural effusion. 4. Calcified pleural plaques. 5. Normal X-ray image. The correct answer is calcified pleural plaques. These are the typical appearances of calcified pleural plaques secondary to asbestos exposure. This is different from asbestosis, which is lung fibrosis secondary to asbestos exposure. Question 3. 20-year-old female with high temperature and cough. Which answer best describes the appearance? 1. Normal. 2. Image inadequate due to patient rotation. 3. Pleural effusion. 4. Lung cancer. 5. Consolidation. The correct answer is consolidation. There is no rotation. This is a good quality image in a patient with a thoracic spine scoliosis. Increased density with air bronchogram in the left lower zone indicates consolidation. Compare with the clear right lower zone. A chest X-ray is not diagnostic of lung cancer, and this diagnosis is very unlikely in this age group. The costa phrenic angles remain well defined, indicating there is no pleural effusion. Question 4. Which finding is present? 1. Normal chest X-ray. 2. Cardiomegaly. 3. Pectus excavatum. 4. Azygous fissure. 5. Free gas under the diaphragm. The correct answer is normal chest X-ray. The heart is not enlarged. There are no features of pectus and the right upper zone. The position of the azygous vein appears unremarkable. There is gas under the diaphragm, but this is in the stomach. This is a beautifully normal chest X-ray. Question 5. Cough, weight loss and finger clubbing. Which statement is true? 1. The image is diagnostic of lung cancer. 2. The image is diagnostic of pneumonia. 3. Blunting of the costa phrenic angles is due to pleural effusions. 4. The lungs are hyperexpanded. 5. The heart is enlarged. The correct answer is, the lungs are hyperexpanded. Increased density and air bronchogram in the right upper zone indicate consolidation, but no chest X-ray is in itself diagnostic of lung cancer or pneumonia. Compare with the normal left upper zone. The lungs are hyperexpanded, green lines equals predicted normal position, which explains the blunt appearance of the costa phrenic angles. There is no pleural effusion. Heart size is normal. Question 6. Which finding is present? 1. Normal. 2. Dextrocardia. 3. Pectus excavatum. 4. Right middle lobe pneumonia. 5. Cardiomegaly. The correct answer is Pectus excavatum. The right heart border is not visible. This is not because of a right middle lobe pneumonia or rotation, but rather because the heart is displaced to the left due to Pectus excavatum. The ribs are angled such that they take on more of a 7 shape rather than their normal C shape. Even if the right side of the heart was in line with the right edge of the spine, the heart size would still be within normal limits. If you think your patient has Pectus excavatum on the basis of a chest X-ray, then the diagnosis should be confirmed on clinical examination. Question 7. Which finding is present in this close-up chest X-ray image? 1. Bronchiectasis. 2. Septal lines, curly B lines. 3. Accessory fissures. 4. Lung fibrosis. 5. Normal chest X-ray. The correct answer is septal lines, curly B lines. Septal lines are a subtle but very useful sign. In the context of clinically suspected heart failure, they indicate interstitial pulmonary edema. Question 8. Which statement is correct? 1. The X-ray is of poor quality and should be repeated. 2. The endotracheal tube should be advanced. 3. The internal jugular catheter should be removed. 4. The nasogastric tube should be removed. 5. The lungs are normal. The correct answer is, the nasogastric tube should be removed. The endotracheal tube tip is located approximately 3 cm above the carina. If anything, it should be withdrawn a little. There is no reason to remove the right internal jugular catheter. For long-term use it may be appropriate to advance further. The nasogastric tube has passed down the right main bronchus into the right lung. It should be removed. Although lung markings are likely exaggerated by patient positioning and incomplete inspiration, they can't be called normal. Question 9. Which physical examination sign would you expect to be present at that time of taking this X-ray? 1. Left-sided bronchial breathing. 2. Tracheal deviation. 3. Right side of chest hyperresonant to percussion. 4. Normal examination findings. 5. Finger clubbing. The correct answer is, right side of chest hyperresonant to percussion. There is a large right pneumothorax, greater than 2 cm width at the level of the hilum. The right side of the chest would be hyperresonant to percussion. The image does not show deviation of the trachea. However, this patient would still need immediate attention. There is no direct association between pneumothorax and finger clubbing. Question 10. What is the most likely cause of chest pain seen in this close-up chest X-ray image? 1. Infection. 2. Cancer. 3. Trauma. 4. Fibrosis. 5. Sarcoidosis. The correct answer is, trauma. Atelectasis at the left lung base may be related to any of these causes, however there is a displaced rib fracture indicating trauma. Question 11: Which one statement is true? On the grounds of imaging appearances alone, the diagnosis is 1. Pneumonia. 2. Lung cancer. 3. Pulmonary contusion. 4. Any of the above. 5. Normal chest X-ray. The correct answer is, any of the above. The image shows right lower zone consolidation. It is not possible to establish the cause without reference to the clinical scenario, which is not stated. Consolidation can be caused by pneumonia, lung cancer, pulmonary edema, or pulmonary hemorrhage/contusion. Alveolar proteinosis is a very rare cause. Both pulmonary edema and alveolar proteinosis tend to cause more widespread bilateral consolidation. Any of the other causes are possible causes of the consolidation seen in this image. Question 12: What congenital abnormality is visible in this chest X-ray of a patient with no respiratory symptoms? 1. Right-sided aortic arch. 2. Tetralogy of Fallot. 3. Dextrocardia with bronchiectasis related to Cartognerous syndrome. 4. Dextrocardia with situs inversus. 5. Dextrocardia with normal situs, situs solitis. The correct answer is, dextrocardia with normal situs, situs solitis. The heart is on the right indicating dextrocardia. The liver and the stomach/colon bubble are in their normal positions indicating situs solitis, normal location of the abdominal viscera. If the liver had been on the left and the stomach bubble on the right, this would indicate situs inversus. The lack of respiratory symptoms makes bronchiectasis related to Carcinoma syndrome unlikely. Question 13: Which structure is visibly normal in this patient with lung cancer? 1. Left upper zone. 2. Left hilum. 3. Left lower zone. 4. Right paratracheal stripe. 5. Right hilum. The correct answer is right paratracheal stripe. The right paratracheal stripe is well defined and is not widened. This line can be widened if there is right paratracheal lymph node enlargement. Both hilum are enlarged and there is nodular consolidation in the left upper and lower zones. Question 14 to 2 images. Patient with lung cancer. Image 1 shows a right hilar mass. What complication has occurred at the time of image 2 which was acquired 4 months after image 1? 1. Lung metastases. 2. Phrenic nerve palsy. 3. Right lower zone pneumonia. 4. Right pleural effusion. 5. Left pneumothorax. The correct answer is phrenic nerve palsy. Image 2 shows the right hilar mass has enlarged. The right hemidiaphragm is raised, indicating phrenic nerve palsy due to compression or erosion by the mass. There is no visible pleural effusion or pneumothorax. Question 15: Patient with cough and fever. Which area is abnormal? 1. Right upper zone. 2. Left upper zone. 3. Both middle zones. 4. Right lower zone. 5. Left lower zone. The correct answer is left lower zone. Consolidation is seen in the left lower zone. Compare with the right lower zone and other areas of the lungs which are clear. Question 16: Which structure is abnormal? 1. Heart. 2. Right hilum. 3. Aortic knuckle. 4. Trachea. 5. None of the above, normal X-ray. The correct answer is none of the above, normal X-ray. All structures are normal. This is a normal chest X-ray. Question 17: Long-standing heavy smoker with a dry cough. Which statement is true? 1. The lungs are hyperexpanded. 2. Blunting of the costophrenic angles is due to pleural effusions. 3. The heart is enlarged. 4. The patient is rotated to their right. 5. The smoking history is irrelevant to interpretation of this image. The correct answer is the lungs are hyperexpanded. The costophrenic angles are blunted. This is because the lungs are hyperexpanded, as indicated by the flattened diaphragm, rather than because there are pleural effusions. If anything, the patient is slightly rotated to the left. The heart is not enlarged. The smoking history is relevant to chest X-ray interpretation. The diagnosis of emphysema cannot be made in patients with hyperexpanded lungs unless the smoking history is known. Question 18 to 2 images. Rapid onset shortness of breath and chest pain. A previous chest X-ray is shown for reference. Image 2. Regarding image 1, which statement is false? 1. The costophrenic angles are blunt. 2. The upper zone vessels are enlarged. 3. The previous image is irrelevant to interpretation of this image. 4. The image is of adequate quality. 5. The diagnosis is consistent with heart failure. The correct answer is, the previous image is irrelevant to interpretation of this image. The previous image, image 2, shows the heart was enlarged. The previous image is relevant to chest X-ray interpretation and should be viewed as a matter of routine whenever interpreting a chest X-ray. Image 1 shows classic features of severe pulmonary edema. The upper zone vessels are enlarged, indicating pulmonary venous hypertension. Bilateral shadowing indicates alveolar edema, and bilateral costophrenic blunting indicates pleural effusions. The combination of severe pulmonary edema in a patient with previously documented cardiomegaly is consistent with the diagnosis of heart failure. Question 19: A chest drain has been inserted to treat a large pneumothorax and a chest X-ray was requested to check its position. Which feature does the X-ray show? 1. Normal appearances. 2. Correctly placed chest drain. Cardiomegaly. 3. Surgical emphysema. 4. Inadequate image. The X-ray should be repeated. The correct answer is surgical emphysema. The chest drain is not fully inserted into the thoracic cavity and placement has been complicated by extensive surgical emphysema over the left side of the chest. The heart appears enlarged but the image is anterior-posterior, AP, so the heart size cannot be assessed accurately. Although the right costophrenic angle is not included on the image, there is no clear reason to retake the X-ray as the clinical question has been answered. Question 20: A 78-year-old woman remains in hospital 4 weeks after a stroke with residual poor swallow. She becomes short of breath with a cough, high temperature and raised inflammatory markers. None of these clinical features were present at the time of admission. The X-ray appearances are most likely caused by which complication? 1. Lung fibrosis. 2. Community-acquired pneumonia. 3. Aspiration pneumonia. 4. Surgical emphysema. 5. Heart failure. The correct answer is aspiration pneumonia. The image shows dense consolidation in the lower zones, worse on the left. In this clinical context, the most likely cause is an aspiration pneumonia. The lack of the clinical features described at the time of admission rules out a community-acquired pneumonia. Heart failure could cause these appearances, but the cough, high temperature, and raised inflammatory markers point towards a respiratory tract infection. There is no evidence of lung fibrosis or surgical emphysema. Question 21: PA image. Which of the following is not present? 1. Cardiomegaly. 2. Left internal jugular catheter. 3. Prosthetic heart valves. 4. Pacemaker device. 5. Sternotomy wires. The correct answer is left internal jugular catheter. The heart is enlarged, cardiomegaly. Visible artifacts include sternotomy wires, prosthetic heart valves, and a pacemaker. There is no left internal jugular catheter in situ. Its predicated position is indicated on the overlay image. Question 22: Athletic 24-year-old female non-smoker with palpitations. Which statement is true? 1. The lungs are hyperexpanded. 2. The heart is enlarged. 3. Multiple rib fractures are visible. 4. Breast asymmetry indicates a previous mastectomy. 5. The image is normal. The correct answer is, the image is normal. At first glance the lungs appear hyperexpanded, but this is an unlikely finding in a young and fit non-smoker. The hemidiaphragm contours remain domed and the anterior ends of the seventh ribs intersect the midclavicular lines at or below the diaphragm. The breasts are very slightly asymmetric, as they are in most normal subjects. Previous breast surgery is not a diagnosis made with an X-ray. Ask the patient or check the notes. Heart size is normal. Question 23: Nasogastric tube insertion with failure of attempted aspiration of gastric fluid. What is the location of the nasogastric tube? 1. Stomach. 2. Within a hiatus hernia. 3. Right upper quadrant of abdomen. 4. Right side of the mediastinum. 5. Right lung. The correct answer is right lung. Feeding through a misplaced nasogastric tube is considered an every vent. This nasogastric tube has passed into the right lung. Feeding in this position carries a high mortality risk. Note the external wires, the right internal jugular catheter, and the bilateral parahilar and left lower zone consolidation. Question 24: Middle-aged male with cough, high temperature and chest pain. Where is the acute abnormality? 1. Right upper zone. 2. Right lower zone. 3. Left upper zone. 4. Left lower zone. 5. Below the diaphragm. The correct answer is right lower zone. There is consolidation of the right lower zone. This could be in the right middle or lower lobes, but this will not change management in this patient with pneumonia. Gas under the diaphragm is in the stomach and there is no history of an acute abdomen to suggest perforation. Note there is a healed fracture of the left clavicle, not an acute abnormality. Question 25: A chest X-ray taken 1 hour earlier showed a large right pneumothorax. A chest drain was inserted, and a repeat X-ray was obtained. Which statement is true? 1. The pneumothorax is now small and so the chest drain can be removed. 2. The chest drain is incorrectly placed and should be removed. 3. The chest drain is adequately positioned. 4. The chest drain has pierced the right lung and should be removed. 5. The chest drain should be replaced by a larger chest drain regardless of the clinical response. The correct answer is, the chest drain is adequately positioned. The pneumothorax remains big. A pneumothorax is considered big if it is wider than 2 cm at the level of the hilum. Although the tip of the tube is projected over the lung, this does not mean that it has pierced the lung. The drain is in a good position. The decision to insert an additional drain, or a larger one, is made on clinical grounds. Question 26: 2 images. Image 1, full-sized image. Image 2, detail image. Patient with chest pain. Which statement is true? 1. Chest X-rays are not required routinely in the setting of clinically suspected uncomplicated rib fractures. 2. There is no cause of chest pain demonstrated on these images. 3. A normal chest X-ray excludes rib fractures. 4. This image shows blunting of the left costophrenic angle indicating a hemothorax. 5. The patient is rotated and so the image is non-diagnostic. The correct answer is chest X-rays are not required routinely in the setting of clinically suspected uncomplicated rib fractures. Chest X-rays are not required routinely in the setting of uncomplicated clinically suspected rib fractures but can be requested if there is clinical suspicion of a complication such as a pneumothorax or hemothorax. The detail image shows a rib fracture on the left. The costophrenic angles are well defined indicating there is no hemothorax. Although the patient is a little rotated, a cause of chest pain, the rib fracture, is demonstrated so the image can be considered diagnostic. Question 27: Smoker with weight loss, hemoptysis, and finger clubbing. The most likely diagnosis is 1. Sarcoidosis. 2. Glioblastoma metastasis. 3. Primary bronchogenic carcinoma. 4. Pneumonia. 5. Normal X-ray. The correct answer is primary bronchogenic carcinoma. There is a large left hilar mass which is most likely due to a bronchogenic carcinoma in this clinical context. The clinical features do not point towards active infection, although on the grounds of the image alone this diagnosis should also be considered a possibility. Sarcoidosis usually causes bilateral hilar enlargement. Glioblastoma metastases outside the central nervous system is rare. Question 28: What is the abnormality demonstrated radiological? 1. Breast asymmetry due to previous mastectomy. 2. Pleural effusion. 3. Air bronchogram. 4. Bilateral hilar enlargement. 5. Phrenic nerve palsy. The correct answer is pleural effusion. This is the classic appearance of a pleural effusion. The meniscus sign is present, which should not be mistaken for a raised hemidiaphragm as in the case of a phrenic nerve palsy. The right breast appears denser because of the fluid in the right pleural cavity. There is no air bronchogram. The hilar structures appear normal. Note the sternotomy wires. Question 29: Chest pain in patient with permanent pacemaker inserted 2 months previously. Which radiological finding is present? 1. Normal image. 2. Pacemaker incorrectly positioned. 3. Pacemaker insertion complicated by large pneumothorax. 4. Left mid and lower zone consolidation. 5. Enlarged heart. The correct answer is left mid and lower zone consolidation. The pacemaker appears correctly positioned. There is no pneumothorax. Although the heart appears enlarged, the heart size cannot be accurately assessed on an anterior-posterior (AP) image. Consolidation is present in the left mid and lower zones. Pneumonia was the cause of chest pain in this patient. Question 30: Which artifact is seen on this chest X-ray detail image? 1. Esophageal stent. 2. Aortic stent. 3. Inhaled foreign body. 4. Sternotomy wires. 5. Tracheal stent. The correct answer is esophageal stent. You may not have come across this artifact before, but an understanding of anatomy helps to determine what it is. The artifact is located outside the contour of the trachea and does not follow the contour of the aorta. It does not have the appearance of sternotomy wires. See questions 1 and 8. Although the esophagus is not visible on a chest X-ray, this artifact follows its contour exactly. It is an esophageal stent, placed to alleviate dysphagia related to an esophageal tumor. Question 31: Regarding this X-ray, the most likely diagnosis is 1. Sarcoidosis. 2. Mesothelioma. 3. Pulmonary fibrosis. 4. Thymoma. 5. Primary bronchogenic lung carcinoma. The correct answer is primary bronchogenic lung carcinoma. There is a large rounded area of increased density in the right lower zone, and enlargement of the right hilar structures. Sarcoidosis usually causes bilateral hilar enlargement and areas of consolidation. Mesothelioma usually presents with signs of pleural disease such as a pleural effusion or pleural thickening. Lung volumes are normal and there is no evidence of reticulation, net-like appearance, of the lungs, so fibrosis is an unlikely cause. A thymoma usually causes widening of the upper mediastinum, which appears normal in this image. The area of density in the right lung base is due to a lung mass and the enlarged right hilum is due to enlarged lymph nodes in this area. The most likely diagnosis is a primary bronchogenic carcinoma. Question 32: 55-year-old male. Which is the most likely clinical scenario? 1. Clinically suspected bowel perforation. 2. The patient has smoked heavily for many years. 3. Unilateral hyperresonance to percussion. 4. Long history of cardiomegaly. 5. Multiple previous exposures to asbestos. The correct answer is, the patient has smoked heavily for many years. Gas under the left hemidiaphragm is contained within the bowel. There is no evidence of perforation. The hemidiaphragms are flattened and located below the level of the seventh ribs, indicating the lungs are hyperexpanded. The lungs also appear of generalized low density. These are features of emphysema, and so a history of long-term smoking is likely, 35 years in this patient. Hyperresonance would likely be bilateral in this patient. The heart is not enlarged. There is no evidence of pleural disease or fibrosis to suggest previous asbestos exposure. Question 33: to 2 images. Image 1, at time of presentation. Image 2 to 6 weeks later, 69-year-old male smoker with a productive cough, fever and raised white cell count and C-reactive protein. He was started on antibiotics at the time of image 1. Which statement is true regarding image 2? 1. Metastatic renal cell carcinoma is the most likely cause of the X-ray appearances. 2. Multifocal consolidation of the lungs is invariably due to pneumonia. 3. Comparison with previous chest X-rays would not be helpful in this setting. 4. The radiological features alone are diagnostic of lobar pneumonia. 5. The areas of consolidation have improved. The correct answer is, the areas of consolidation have improved. The areas of consolidation seen on image 1 have improved on the second image. Renal cell carcinoma can lead to similar appearances, but the rapid improvement following antibiotic treatment points towards infection as the cause. Comparison with previous images is always helpful if they are available. No radiological feature is ever diagnostic of a pneumonia. Even if pneumonia was considered to be the diagnosis, in this case the distribution is not that of a lobar pneumonia, as the multiple areas of abnormality are not in a specific lobe of the lungs. Question 34: On seeing this chest X-ray, which of the following actions is most appropriate? 1. Immediately return to reassess the patient and alert your team of the X-ray findings. 2. Request a CT of the chest with intravenous contrast. 3. Request an ultrasound of the abdomen. 4. No action is necessary, the image is normal. 5. Request a repeat X-ray, it is underpenetrated. The correct answer is immediately return to reassess the patient and alert your team of the X-ray findings. This is a large left pneumothorax, greater than 2 cm width at the level of the hilum. There is also evidence of tension, the trachea and right heart border are shifted to the right and there is slight depression of the left hemidiaphragm. This is a medical emergency requiring the immediate attention of you and your team. Question 35: 29-year-old male, presented with cough and pleuritic chest pain. What is the radiological diagnosis? 1. Metastatic disease. 2. Pulmonary fibrosis. 3. Sarcoidosis. 4. Surgical emphysema. 5. Normal appearances. The correct answer is, normal appearances. This chest X-ray is entirely normal. There is no evidence of metastatic disease, pulmonary fibrosis, sarcoidosis, or surgical emphysema. Question 36: 2 images, one with and one without marking, what does the anatomical line marked on image 2 represent? 1. The anterior junctional line. 2. The right heart border. 3. The right paratracheal stripe. 4. The azygoesophageal line. 5. The descending thoracic aorta. The correct answer is, the azygoesophageal line. This is the azygoesophageal line. This line is formed by the contrast of the low-density lung at its interface with the relatively higher-density soft tissues of the mediastinum formed by the vertically orientated esophagus and azygous vein. Question 37: What are the chest X-ray appearances most likely due to in this patient with a cough? 1. Pulmonary edema. 2. Lung metastases. 3. Tuberculosis infection. 4. Previous spontaneous pneumothorax. 5. Sarcoidosis. The correct answer is, tuberculosis infection. Consolidation of the right upper zone is accompanied by enlargement of the right hilum. These are typical appearances of primary Mycobacterium tuberculosis infection. Pulmonary edema is a cause of consolidation, but distribution is usually bilateral and affects the perihilar or lower parts of the lungs. Previous spontaneous pneumothorax does not usually leave any signs of abnormality in the lung affected. Although sarcoidosis does cause hilar enlargement and parenchymal disease, these changes are usually bilateral. Question 38: Which of the following features is present? 1. Dextrocardia. 2. Bilateral pleural effusions. 3. Pericardial effusion. 4. Hiatus hernia. 5. Normal chest X-ray. The correct answer is hiatus hernia. There is a round area projected over the lower mediastinum due to the stomach passing superiorly through the hiatal orifice into the thorax, a hiatus hernia. Within this area superiorly there is low density, asterisks, which represents gas in the herniated stomach. The heart contours are normal and the costa-phrenic angles are well defined. Question 39: Which statement is true? 1. The image shows a finding which could be explained by recent laparoscopic surgery. 2. Urgent CT scanning is required regardless of the clinical context. 3. The abnormality is obvious and so a systematic approach is not required. 4. The image is of poor quality and should be discarded and repeated. 5. The heart is enlarged. The correct answer is the image shows a finding which could be explained by recent laparoscopic surgery. There is a thin crescent-shaped low-density line under the right hemidiaphragm indicating free gas in the abdomen. This appearance can be due to perforation of an abdominal viscus or may be due to residual intra-abdominal gas following laparoscopic surgery. The normal stomach bubble is seen on the left. When considering imaging with CT, the clinical context must always be considered. It is a higher radiation dose investigation, so should be avoided if not necessary. A systematic approach is always required. The image is diagnostic and so should not be repeated. The heart is not enlarged. Question 40. Detail image. The radiological feature shown is 1. Diagnostic of sarcoidosis. 2. Not a significant finding in the context of suspected heart failure. 3. Diagnostic of lymphangitis carcinomatosa. 4. A normal variant. 5. A sign of interstitial pulmonary edema. The correct answer is a sign of interstitial pulmonary edema. Septal lines, curly B lines, are seen at the lung base. Thickening of these lines such that they become visible is caused by fluid in the interlobular septa. This is a sign of interstitial pulmonary edema in the context of suspected heart failure. Thickened septal lines can also be seen in sarcoidosis and lymphangitis carcinomatosa. This is the end of this quiz. Thank you for watching and goodbye.